Well, thank you. Thank you. I'm thrilled to be here to talk about prevention and treatment of COVID-19 in an immunosuppressed patient population. This is, I believe, a critically important topic. In the United States, almost 3% of the population are considered immunocompromised. That's more than 500,000 people in the US alone. Today, I'll be talking about potential consequences first of COVID-19 for the immunosuppressed patient. I'll try to do this in a case-based format. We'll then talk about options for prevention and then management options when first-line therapy fails. So I want to start off with a case from actually back in the summer of 2020. And this is a case of long-term COVID relapse, and it helps define what are the potential consequences of COVID-19 disease in our immunosuppressed patient population. This is a 45-year-old man who was diagnosed with catastrophic antiphospholipid antibody syndrome. And the patient's rheumatologist had told me that this was the most severe case that he had ever seen in his career. The patient was heavily immunosuppressed on rituximab, eculizumab, steroids, cyclophosphamide, and ruxolitinib. So someone who had immunosuppression of the B cell, complement, and T cell systems. The patient was diagnosed in the summer of 2020 with COVID-19 and readmitted multiple times over the subsequent 5 months with dyspnea and other symptoms. And you can see on the right-hand side, this is the CT value, psychothreshold values from the patient's qPCR from the nasopharyngeal swab. From the initial infection, additional recurrences over time. You can see this patient had again and again multiple relapses over time, including 5 months after the initial infection when the CT value was extremely low, which means high viral load. So the question to me at the time was this patient being reinfected with new strains, or actually someone who was dealing with chronic infection? And we were able to perform viral sequencing of multiple different time points and put it onto a phylogenetic tree. And when we put the sequences on the phylogenetic tree, seen here in the arrows in the bottom right-hand corner, we saw sequence evidence of persistent infection. When all of these sequences were actually had the same ancestors and came off of the same root. And so this is someone who does not have recurrent infection, but instead persistent infection. So does this patient have infectious virus? We were told at the time by the CDC that our patients were no longer infectious after about 10 days of symptoms. And we were able to take the patient samples and try to culture them. On the top left corner, you see a negative control where there is a nice lawn of cells. On the upper right-hand corner, you see a positive control where the lawn of cells has now been disrupted by a cytopathic effect of virus. And when we take patient samples from day 75 and day 143, what you see is that there is cytopathic effect and evidence of infectious virus all the way through day 143, or 5 months after the initial infection. This patient continued to shed high levels of infectious virus. So unfortunately, the patient continued to worsen clinically. He required mechanical ventilation, and a bronchoalveolar lavage on day 150 showed an RT-PCR CT value of 15.8, which is extremely low, so high levels of viral load. Also had a positive culture for Aspergillus fumigatus, for which he received antifungal treatment. His respiratory hemodynamic status unfortunately continued to decline until he passed on day 154, 5 months after initial infection. An autopsy was performed and tissue samples were acquired for pathology and RNA extraction. And first of all, the pathology did confirm the infection with SARS-CoV-2, as well as an infection with Aspergillus pneumonia, as you see in the white arrow. In addition, the patient had evidence of his underlying disease, including diffuse alveolar hemorrhage, or DAH. When we were obtained tissue for SARS-CoV-2 viral RNA, viral load testing, we found that yes, indeed, most of the viral RNA were found in the lungs, but we're also able to find viral RNA across multiple organs, including spleen, heart, liver, and then also the gastrointestinal tract, really showing that in this patient, there was dissemination of SARS-CoV-2 infection throughout the body. This case, I think, highlights a couple of important points. One, that our immunosuppressed patients are at risk of severe disease, but also of chronic infection. And in addition, the dissemination of virus across the body increases their chance of viral evolution and resistance emergence and other negative effects as well. So what are the options for prevention for our patients? Well, historically, we've had COVID-19 vaccines. We've had, of course, non-pharmacologic measures like masking, as well as monoclonal antibodies like tixagevimab, silgevimab, also known here as Evusheld. So we'll start off by talking about, well, what about what we have available now? And unfortunately, while COVID-19 vaccines and masking and other non-pharmacological measures remain effective, monoclonal antibodies for pre-exposure prophylaxis is unfortunately no longer, you can no longer count on it to prevent infection. And we'll talk about why that is. So let's talk about vaccines first. So in both our messaging and research, there's been an intense focus on both antibody responses and especially neutralizing antibody responses. And I agree that antibody responses are critical, but I think we should be aware that vaccines can boost multiple arms of the immune response, and that there's likely to be value even for those who are unable to mount a sufficient humoral immune response. So this is a study that I'm showing here of comparing immune responses of patients with autoimmune disorders receiving rituximab compared to those who are non-immunosuppressed on the far left side, the gray, as well as those who are receiving other immunosuppressive agents in the blue, mostly steroids, methotrexate, mycophenolate. And the first graphs I want to show are the antibody responses. And you can see that there are fewer individuals in the rituximab group in the red who had anti-spike antibody titers or neutralizing antibody titers compared to either those who are not immunocompromised in the gray or those taking other immunosuppressive agents in the blue. Now, it's also important to note that for those who are on rituximab, if there is a longer duration of time since the last infusion, it also meant that they were more likely to mount an antibody response. So the timing of vaccine compared to the rituximab and anti-CD20 kind of antibody and treatments does seem to matter. Now, also importantly, functional SARS-CoV-2 specific CD4 and CD8 T cell responses were not particularly different between rituximab treated group compared to either the non-immunosuppressed patients or the other immunosuppressed patients. And this is why even in those who I believe are unlikely to mount an antibody response, I will still make sure they're up to date on their vaccinations because they may still be able to get benefit from T cell responses and non-B cell responses. And there is increasing data that those responses can also help prevent severe disease. So what about tixagevimab, silgevimab, otherwise known as Evusheld here? And we know that in phase 3 trials that it does prevent symptomatic COVID-19 infection. This is the main graph from the phase 3 studies showing a 77% reduction in symptomatic COVID-19 infection. So, I mean, that seems great. So why am I so down on the ability of this monoclonal antibody combination in preventing infection? Well, that is because in both the United States and worldwide, there is the emergence of monoclonal antibody resistant Omicron subvariants. And I'm showing you data from the US CDC for the United States, showing you the mix of variants here in the figure right in front of you, that BA.5 is increasingly being replaced by other Omicron subvariants, specifically BQ1 and BQ1.1, and many of these other variants are unfortunately resistant to Evusheld, tixagevimab, silgevimab. In the United States, more than 80% of all the variants are now resistant to Evusheld. And so it is something that we just unfortunately cannot count on for our patients to prevent infection, unfortunately. And over time, we have seen that the anti-SARS-CoV-2 antibodies have fallen one by one to the Omicron subvariants. That as each of the Omicron subvariants have come out, they have increasing immune escape properties, and we have lost bamlanivimab, adesivimab, casirivimab, and devimab, and then sotrovimab, and now, unfortunately, with BQ1 and BQ1.1 being the dominant variants in the U.S., we have now lost bebtelovimab for treatment and tixagevimab, silgavimab for prevention, and that is seen by the current antiviral options against the newest Omicron subvariants. That in the United States right now, we have as the most preferred options nirmatrelvir, ritonavir, or Paxlovid, Remdesivir, and molnupiravir, and bebtelovimab and Evusheld are no longer, I believe, particularly efficacious. And actually, the FDA has revoked the EUA for bebtelovimab as well. Now, nirmatrelvir, ritonavir, Remdesivir both have high efficacy, as you've heard, but there are weaknesses with nirmatrelvir. There is drug interactions and viral rebound. With Remdesivir, you have complicated IV dosing that requires 3 days of outpatient dosing for outpatients. And molnupiravir has, people believe there's lower efficacy and some potential for mutagenesis as well. So let's go to the second case when first-line therapies failed. This is a middle-aged man with follicular lymphoma who's recently treated with obinutuzumab, which is an anti-CD20 antibody that depletes B cells. Bendamustine and steroids. Bendamustine induces apoptosis and also inhibits B and T cells. Diagnosed with COVID-19 5 months prior, transiently improved with 5 days of Paxlovid, but the fatigues and shortness of breath persisted. COVID qPCR positive again a couple months prior and retreated with Paxlovid, but persistent fevers and dyspnea. Received 3 days of Remdesivir a month ago and now seen in clinic with nasopharyngeal swab CT values of 19. So low CT values, high viral load. So questions that I wanted to explore include, well, could there be resistance to Paxlovid or Remdesivir, or can you freely retreat again as needed? Could combination therapy be better? And what about convalescent plasma? But before we talk about nirmatrelvir, ritonavir, Paxlovid resistance, I want to take a quick detour and talk about the importance of assessing for drug interactions in our immunosuppressed patients. Like most protease inhibitors that we use for other diseases like HIV, nirmatrelvir is co-formulated with ritonavir for pharmacologic boosting. Ritonavir inhibits the cytochrome 3A4 and the P-glycoprotein to increase levels of nirmatrelvir. That has been well demonstrated, and as shown here on the left-hand side, this pharmacokinetic study that shows levels of the nirmatrelvir in red, red and black, but the nirmatrelvir that's boosted with ritonavir in red is far higher than the nirmatrelvir alone in black. Ritonavir, however, is also one of the kings of drug interactions, and it's going to be important to check for drug interactions. You can use the Liverpool Drug Interactions website, the NIH COVID-19 Treatment Guidelines Panel website. The Ontario Group, which is what I'm showing you here, has listings of medications that should be avoided with or altered dosing with nirmatrelvir, ritonavir, including immunosuppressants that is important for our patients. All right, so let's talk about Paxlovid resistance. Fortunately, it appears to be very rare. On the left-hand side, I'm showing you the US FDA fact sheet for healthcare providers. It outlines the risk of resistance, and I'm highlighting you the relevant paragraph on antiviral resistance in clinical trials. It shows that in the phase 3 EPIC-HR trial, there were a number of polymorphisms that were detected in those who received Paxlovid or nirmatrelvir, but that there's really one mutation, E166V, that was associated with nirmatrelvir resistance in cell culture that was seen in 3 patients out of 361, or 0.8%. Now, none of these mutations occurred in nirmatrelvir ritonavir patients who experienced hospitalization, so they're really unclear clinical significance. Also, in cases of Paxlovid rebound, including ones that were done at our institution, really have not yet reported any resistance so far. And so I think so far, fortunately, Paxlovid resistance appears to be very rare. So what about Remdesivir resistance? Well, I have to say we still don't really know how common Remdesivir resistance is. In the first case that I presented, our patient was treated with several doses of Remdesivir, and actually we did not detect any Remdesivir resistance despite multiple doses, but there have been a number of published reports in the literature, including this one that I'm showing you here. This is a patient with non-Hodgkin's lymphoma who's also completed a course of rituximab and bendamustine, which I think should sound very familiar because that's the same treatment as similar treatment as the patient that I just mentioned, with persistent lymphopenia and hypogammaglobulinemia. This patient developed COVID-19 in May 2020. He was hospitalized with low CT values, and then eventually treated with a 10-day course of Remdesivir, shown here in the gray box. There was a little bit of initial improvement. You can see the initial decrease here in the saliva and nasopharyngeal swab viral load, and then a rebound. And this rebound was associated with the emergence of resistance mutation E802D, which occurred about 7 days into his Remdesivir treatment. The patient eventually received casirivimab, monoclonal antibodies shown here in the purple, and then with the eventual resolution of infection. So this does suggest that Remdesivir resistance could potentially occur, and we should be worried a little bit in our immunosuppressed patient population. I do want to mention that even though monoclonal antibodies are no longer kind of effective for treatment, that has been associated with high levels of resistance in our immunosuppressed patient population. This is a study of sotrovimab within the immunosuppressed patient population, 43 individuals with sotrovimab with immunosuppression compared to 14 immunocompetent patients. Resistance of emergence was seen correlated with immunodeficiency. Actually, a third of the patients who were treated with sotrovimab had within the immunosuppressed population had resistance. But what about combination therapy? Could it decrease the risk of resistance emergence? And it appears the answer might be yes, that a combination of sotrovimab plus remdesivir appeared to decrease the risk of resistance. And I've highlighted the relevant sentence here that is negatively correlated with the occurrence of resistance mutations. What about efficacy? Could combination therapy also be more potent? We unfortunately don't have much data in humans. There are some case reports of people, doing okay, doing better with combination therapy, or actually clearing their infection with combination therapy, but really just anecdotal reports. So we have to rely a little bit more on animal models. This is a study of combination of Paxlovid and molnupiravir in a non-human primate study, and it seemed to suggest that it was more potent. On the gray bars are those who received no treatment. The red is the molnupiravir alone. Orange is Paxlovid alone, and then blue is the combination. There were 5 animals in each group. On the left here, you can see that is clinical scores, clinical symptoms and scores. You can see the lowest clinical scores in those who receive combination. In the middle is viral load swabs. And you can see at day 2, maybe slightly lower viral load in the combination group, but actually the nirmatrelvir, ritonavir, Paxlovid actually does pretty well even by day 4 for nasopharyngeal swab viral load. Looks maybe a little bit better than molnupiravir. But this is BAL, so lower respiratory tract. It does appear that combination therapy, you do get lower initial decays in day 1 and day 2, although by day 4, similar levels to the nirmatrelvir group alone. But also they showed that combination treatment also seemed to produce fewer lung changes on autopsy, and for unknown reason, actually increased lung levels of both molnupiravir and Paxlovid. So this is promising, but we really, really need more human studies. And so finally, what about convalescent plasma in the US? It is FDA authorized for immunosuppressed patients for treatment of COVID-19. And this is based in part off of a phase 3 study in outpatients who were treated with Convalescent plasma, which showed a 54% decreased risk of severe disease. The main problem is that the newer variants have really concerning immune escape properties. This is a preprint looking at the neutralization titers needed to neutralize some of the new variants. And you can see here that for BQ1, BQ1.1, and also some of the XBB, which is another new variant, which is concerned about, you get far lower neutralizing titers, 20 to 40-fold less for BQ1, BQ1.1, and 60 to 80 times less for XBB. This is in patients who receive 3 shots of mRNA vaccine plus a bivalent booster. So it's really not completely clear to me how the 54% kind of efficacy is going to fare in the setting of more immune resistant or escaped variants. So in summary, immunosuppressed patients are at risk of severe chronic COVID-19. Vaccination can boost T-cell responses even with B-cell immunosuppression, and I do recommend it for all of my patients. Monoclonal antibodies, including bebtelovimab and Evusheld, are largely no longer effective. We just can't count on it when it comes to BQ1, BQ1.1, and other newer Omicron subvariants. Combination antiviral therapy has been reported to decrease the risk of resistance emergence and has intriguing potency data, but controlled trials in humans are desperately needed. And finally, convalescent plasma has potential, but there will be decreased efficacy versus the new Omicron subvariant. So thank you very much, and I'm happy to take questions.